We are live.
A very good evening, everyone. Welcome to the iFocus online lecture 424 of the Cataract module. For the session today, the topic is Nanophthalmos, relative anterior microphthalmos, and axial hyperopia. For the session, I would like to welcome our moderator, Sir, Dr. Prafulla, Sir. He's finished his MD senior residency in cornea, cataract, and refractive from RPC AIMS, New Delhi. Sir is also the additional professor at RPC Center, AIMS, New Delhi. Sir is also the current secretary for DOS, Delhi Ophthalmic Society. Sir is the chief editor of Ophthalmology Clinics 2, and Postgraduate Ophthalmology book series. Sir has published over 395 Google Scholar and 156 PubMed Index papers, over 50 chapters in national and international books. He's won various awards like Best Surgical Technique Award from RANSPO, Young Achiever Award at ISCKRS, Ajit Babu Maji Award, and awards for Best Paper in various conferences. Sir is also the principal investigator in 2 ICMR trials, 4 PIN 18 trials, including 2 multi-center international trials. Welcome, sir.
Thank you, Garvita.
I would now like to introduce the chairperson for the session, Dr. Arvind Kumar, sir. Sir has finished his MBBS and MS from Rajasthan University of Health Sciences, Jaipur. Sir has finished his fellowship in Pediatric Ophthalmology Fellowship from Mahatma Eye Hospital, Nagpur. Sir is currently the additional professor and head at Cataract, Glaucoma, Refractive, Squint, and Pediatric Ophthalmology and Medical Retina Services at AIMS, Hyderabad. Sir has won various awards. He was the first Indian to win Ophthalmic Star Awards at Amsterdam ESCRS 2021. Also, the AIOS International Hero Award for year 2021, 22, 23, and 24. Sir is also the first to receive AIOS Senior Academic Achiever Award in 2021. He's also won IIRSI Gold Medal, Best Innovation, Best Cornea Video, Free Paper Award, the IFA DOS Best Video Award. He's been conferred with 12 Oration Awards. Sir has also won the Best Video Award and IGO Honor, Teachers of Tomorrow Award, and the Best Poster Award by AIOS. Sir has presented over 600 presentations at national and international platforms. Sir has also published over 100 publications in international and national level. Sir is also the associate editor at UKJOS, section editor of IGO, the editorial board member, EC Ophthalmology, WJCC, IJOVS, DOS Times, and JHOS. Sir has also served as the international faculty at SICSSO, WOC, ICO, and ESCRS. Welcome, sir.
Thank you, Dr. Garvit, for such kind introduction.
I would like to now introduce the speaker for the session, Dr. Komal ma'am. She is currently working as an associate consultant with Center for Sight, New Delhi. Ma'am has finished her MBBS from Jawaharlal Nehru Medical College, AMU, Aligarh. Ma'am is a gold medalist at MS in VMMC and Safdarjung Hospital, Guru Gobind Singh Indraprastha University, New Delhi. Ma'am has also finished her DNB Ophthalmology and the senior residency from VMMC and Safdarjung Hospital, New Delhi. She's also gotten her FICO Fellow of International Council of Ophthalmology. She's also finished Advanced PG Diploma in Clinical Research and Medical Writing from Switzerland. Ma'am is a trained and certified cataract and refractive surgeon and is actively involved in training DNB and fellow students. Ma'am has delivered multiple presentations and numerous publications in national and international journals. Ma'am has also won awards for best case presentations and ophthalmic quiz competition. Welcome, ma'am.
Thank you, Garvita. Thank you so much.
I would now like to request the speaker to please share the screen and please let's begin with the class, ma'am.
Good evening. So the topic of discussion today is challenges in cataract surgery in a small eye. So what constitutes a small eye? The major biometric parameters to consider while classifying a small eye is axial length of the eye, anterior chamber depth, and corneal diameter. Holiday classified eyes into 9 types on these biometric parameters. So we can classify a small eye into a microphthalmic eye, which can be a simple or a complex microphthalmos, or a relative anterior microphthalmos, axial hyperopia, or a nanophthalmos. A simple microphthalmos is defined as an axial length that is 2 standard deviation less than the age-adjusted mean, that is less than 21 millimeters, a short anterior chamber depth with a normal scleral thickness and no anatomical malformations. A complex microphthalmos is defined when there are concomitant anatomical malformations with microphthalmos like anterior segment dysgenesis, iris or chorioretinal colobomas, retinal dysplasias, and persistent fetal vasculature. Relative anterior microphthalmos is when axial length is normal, that is, the axial length is more than 20.5 millimeter, but the anterior chamber is shallow, less than 2.2 millimeters, with a small cornea, less than 11 millimeters. In these eyes, the scleral thickness is normal, and there are no other malformations. So the anterior chamber here is crowded, and there is high incidence of angle closure glaucoma, pseudo-exfoliation, and corneal guttata in these eyes. Axial hyperopia is defined as axial length less than 21 millimeters with a normal anterior segment, that is the size of the cornea, the anterior chamber depth is all normal. So when the axial length is short, a patient has hypermetropic refractive error. About 1 millimeter decrease in axial length causes around 3 diopters of hypermetropy. And we define nanophthalmos as an eye which has short axial length, less than 21 millimeter, a shallow anterior chamber that is less than 2.2 millimeter, along with a thick choroid and sclera complex, more than 1.7 millimeters. There are no other anatomical malformations, and the incidence of nanophthalmos is almost 1 in 1,000. So these eyes are prone to angle closure glaucoma. As with advancing age and with cataract formation, the lens thickness increases disproportionately to as compared to the anterior chamber depth. Angle closure glaucoma has there is an incidence of 54 to 77% in nanophthalmic eyes, and it may be due to pupillary blocks, a plateau iris configuration, choroidal expansion, or a forward lens movement due to laxed zonings. Nanophthalmic eyes are also prone to uveal effusions with exudative retinal detachments due to increased scleral thickness. So when scleral thickness increases, there is congestion of vortex veins, and which causes leakage from the choroidal vessels. Along with that, there is a decrease in transscleral outflow. This leads to fluid accumulation in choroid and a dysfunction in pump mechanisms of RP and subretinal fluid collection. So when operating on a small eye, there are many points to consider, and a meticulous planning should be done preoperatively. There is a shallow anterior chamber, so maneuverability is difficult. There is angle closure with synetia formation, so IOP may be high. The lens thickness is much more than a normal lens, which leads to, again, decreased space to maneuver your instruments. And with uveal tract thickening and choroidal effusions, there is a chance of suprachoroidal hemorrhages or serous detachments during the surgery. So there are high rates of intra and post-operative complications, and there is poor post-operative refractive predictability in such cases. So managing patients' expectations is very important in these cases. You should keep the patient informed of the post-operative outcome that you are expecting, keep them informed about the refractive unpredictability of the formulas and a chance of refractive errors, and also any intra and post-operative complications that may arise due to the surgery. So coming to evaluation of visual acuity. So as I discussed, when the axial length is short, the patient has hypermetropia, and hypermetropia has high incidence of amblyopia. So visual acuity should be evaluated in detail. You should ask leading questions to the patient regarding their visual acuity prior to development of cataract. These eyes have retinal dysgenesis and other complications, other malformations as well. So the visual acuity may be low to start with. And when you see the patient with a good formed cataract, you should be aware that visual recovery will may not be what you expected because of the pre-existing amblyopia or other malformations. So short axial length is associated with hyperopia, but you may see myopia as well because of induced myopia due to nuclear sclerosis. So you should always evaluate for amblyopia, look for anisometropia, and if possible, go over past refractive history of the patient. If they have any records of their refraction few years before then when you are seeing, you should go over that to manage patients' expectations. So white to white measurements for corneal diameter, we call it microcornea if it is less than 10 millimeters. These measurements can be done either manually or using a digital calipers, or you can use an optical biometer or a pentacam for the same. These patients also have a high incidence of endothelial dystrophies. So a meticulous slit lamp biomicroscopy is important to evaluate endothelial cell health. If you have the means, go for a specular microscopy to look for the morphology of the endothelial cells, and do a corneal pachymetry because corneas in these cases are thicker than normal. Next, coming to evaluation for anterior chamber depth. Intraocular pressure and an anterior chamber depth should be documented. Anterior chamber depth is less in hyperopic eyes as compared to the emetropic eyes. A gonioscopy should be performed to evaluate the anterior chamber angle. A high IOP with a narrow anterior chamber has high risk of going into angle closure glaucomas. So if you do an iridotomy in these cases, especially if there are anterior synechiae, so it will help in increasing the anterior chamber depth, and which would make maneuvering during surgery easy. So these patients are prone to angle closure glaucoma because as the cataract forms, the lens starts thickening. So in an eye which already has a shallow anterior chamber, if the lens thickens, so there is opposition and closure of the anterior chamber angle in such cases, which leads to a angle closure glaucoma. Evaluation of any anterior segment dysgenesis, colobomas, and retinal dysgenesis should be done. Anterior segment OCT and UVM are helpful in documenting thickened sclera and also a large lens in a small anterior segment. So scleral thickness is measured on anterior segment OCT. You can see the anterior and posterior scleral borders. You have to draw a tangent on the anterior scleral border 6 millimeters posterior to the scleral spur. So this is the scleral spur. 6 millimeter posterior to the scleral spur, draw a tangent on the anterior scleral border. And from this point, a perpendicular is dropped towards the posterior scleral border, and this distance is taken as a scleral thickness. Ultrasound B scan will show you a short eye with thickened sclera. A multi-layered you can also see uveal effusions, which may appear as multi-layered detachment pattern, which is very mobile when you ask the patient to move their eye during ultrasound B scan. These detachments may be very mobile. You can also make out an edematous anterior uvea with lacunae and cysts on ultrasound B scans. Coming to biometry and intraocular calculations. So, IOL calculations are highly unpredictable if the patient has high hyperopia. Especially if the IOL power is more than 30 diopters, the variability increases to plus minus 1 diopter in 43 to 62% of cases. So, your patient should be aware of chances of residual refractive errors and possible need for additional intraocular manipulations. So, three variables are used for IOL calculations. First is keratometry, second is axial length, and third is effective lens position. So, this effective lens position has a far greater effect on refraction if the IOL power is high. So, the best formula to use is the one that predicts the ELP most accurately. Another important consideration is relative size of anterior chamber as compared to the axial length. So, in cases of a shallow AC, shorter anterior chamber depth and shorter axial length, the biometric formulas are more accurate if as compared to the normal anterior chamber depth with short axial lengths. Most accurate method for axial length calculation is an optical biometry, whether a partial coherence interferometry may be used or an optical low coherence reflectometry may be used. Third generation formulae, we use Hofer Qs because these are Hofer Q is very predictable for axial lengths less than 22 millimeters. Nowadays, we have new formulas like Holiday 2, which includes which has multiple inputs like anterior chamber depth, white-to-white measurements, lens thicknesses, refraction, and age of the patient. A newer formula is coming up. That's the Kane IOL calculation formula, and multiple studies have reported its accuracy to be at least same as Holiday 2 and Hofer Q, and better than SRKT, especially in cases of short axial lengths. So when you are operating on the second eye, you may refine IOL power calculation using the post-operative refractive results from the first eye. Since these eyes have very high IOL power, you have to decide whether you are putting a single intraocular lens in this eye or a lens in the bag and one in the sulcus, that is the piggyback eye. Another decision that as a surgeon you have to take is whether you want to perform this surgery in a single stage, like putting two IOLs at the same time in these eyes, or a two-stage procedure. Because these eyes are small, you may want to evaluate the space in sulcus post-operatively. You may want to refine the refractive results post-operatively and plan the surgery as a two-stage procedure. So if you are going for a piggyback IOL in the same stage, you can use a Holiday IOL consultant, which can give you IOL power for the in the bag lens and also for the piggyback IOL. Or you can use Nishaman normograms, which determines the residual refractive error and multiply it by 1.5 to yield the IOL power to be placed in sulcus. So surgical technique in these cases, if the eye is small, it may appear to be deep set. When you start operating, the eye may appear to be deep set. So some surgeons, they put orbital blocks so that eye comes forward and you get more space to operate. But giving a retrobulbar or a peribulbar block may also increase the posterior pressure and vortex vein congestion and may lead to a difficult surgery. Also, if there is a colobomatous scleral staphyloma, which is associated with such microphthalmic eyes, a block has higher chance of block perforations. So topical or intracameral anesthesia is the safest in these cases. Also, you can give 20% mannitol preoperatively if there are no other contraindications, systemic contraindications for the same, to bring down the vitreous pressure and increase anterior chamber depth. A surgeon may sit temporally because horizontal diameter in such cases is more than the vertical diameter, so you get more space to operate. A clear corneal incision is preferred. It reduces the chances of iris prolapse. A wound construction should be proper. You should have a square wound construction so that iris prolapse and does not happen and anterior chamber is stable. We try to keep a small incision length because and corneal pachymetry is high. The central corneal thickness is high. So when you make a corneal tunnel, it may lead to a longer tunnel, which again it becomes difficult to maneuver your instruments. So it is very important to maintain anterior chamber depth, maintain the IOP of the eye at all times. Because if there is fluctuation in IOP, it increases the chances of serous or hemorrhagic choroidal detachments. So you can use either an anterior chamber maintainer or you can use cohesive viscoelastics for the same. If a serous or hemorrhagic choroidal detachment appears, if the AC starts shallowing, there is high posterior pressure, you may do a sclerectomy or sclerotomies and abandon the surgery and resume afterwards when the pressure differential has resolved. Some surgeons also do a vitreous tap during the surgery. A vitrectomy can be done to decrease the posterior pressure. A vitrectomy is slightly trickier in such cases because anatomic landmarks are not same as the normal eye. So your pars plana may be very small or maybe non-existent. A scleral window surgery could serve as an outflow pathway for suprachoroidal fluid accumulating during or after surgery, and it minimizes the chances of uveal effusion. So a scleral window surgery or a sclerotomy can be done 2 months prior to the planned cataract surgery. But you have to remember that not all small eyes will develop posterior segment complications. So if the angle configuration is normal, there is no angle closure, there is no glaucoma, IOP is normal, the posterior segment is normal, you may skip this anterior sclerotomies. So anterior sclerotomy has to be done when there is anterior chamber shallowing during the surgery. So do an anterior sclerotomy, close the eye and resume the surgery at a later date. You have to go for a prophylactic anterior sclerotomy if the patient already has some uveal effusion, or has a thickened sclera and choroid. So it is better to go for a sclerectomy or a sclerotomy 2 months before surgery. If there is acute or chronic angle closure glaucoma, do an anterior sclerotomy along with a peripheral iridectomy before proceeding with the surgery. You can use a soft shell technique to protect your endothelial cell layer from fluid turbulence. These patients also have suboptimal dilations and small pupils, so an iris expansion device or iris hook may be necessary during the surgery. Iris prolapse is very common during surgeries on small eyes. So during hydrodissection, just put gentle pressure on the posterior lip of the corneal wound and it may minimize the iris prolapse. Also, when you are coming out of the eye, put some cohesive viscoelastic in the eye so a sudden decompression of the chamber does not occur, and stop your irrigation while you are removing instrument from the eye. Phaco should be done inside the bag as much as possible. Nucleus prolapse should be avoided because these nucleus pieces would go and touch the endothelial cells and endothelial cell layer and also your phaco energy would harm the endothelial cell. So you may opt for a primary placement of 2 IOLs in the capsular bag, but it has been noted to have high incidences of interlenticular membranes and opacification and an hyperopic shift later on. So a piggyback IOL is preferred. One IOL can be put in the capsular bag and another 3-piece IOL can be put in the ciliary sulcus. So we have to assess sufficient space in the sulcus for a piggyback IOL because as these eyes have less space. So Alcon SA6080 is available in high powers in India, 30 to 40 diopters. Piggyback IOLs are put in the sulcus. These are usually 3-piece IOL, maybe single-piece IOL also. There is angulation in these IOLs so that they are separated from the iris. Otherwise, these iris movements on these IOL may cause pigment dispersion. During the surgery, surgical iridotomy can be done to facilitate post-operative zonulotomy or hyalodotomy in case if malignant glaucoma appears in the post-operative period. The aspiration of viscoelastics and corneal hydration should be done very slowly to avoid iris prolapse, and it is always better to suture the wounds at the end of the surgery. So, as discussed before, these eyes have high incidences of complications as well. So it's 5.76 to 27.9% patients have elevated IOPs. Posterior capsular rupture, zonular dehiscence, iris prolapse, corneal endothelial or descent membrane trauma, transient corneal edema, cystoid macular edema, severe uveitis, effusions, angle closure, and malignant glaucoma are the most common complications seen with these patients. So severe anterior uveitis occur in 3.8 to 12% of patients, but this uveitis has a good response to steroid eye drops. You can see an elevated IOP following phacoemulsification, which may be due to angle closure or a malignant glaucoma. UBM can differentiate the two, whether it is due to aqueous misdirection or angle closure due to a uveal effusion. So if it is aqueous misdirection, which appears in almost 0.4 to 6% of cases, it has to be managed medically using cycloplegics and mydriatics, aquasuppressants, or hyperosmotics. And YAG laser with anterior hyalodotomy can be done, or a transscleral diode laser cyclophotocoagulation to decrease the aqueous formation can be done. Surgically, iridectomy, hyalodotomy, zonulectomy can be done, or through the iridectomy that was made during the surgery, or via pars plana. And if the malignant glaucoma does not resolve by any of these procedures, a complete pars plana vitrectomy or a drainage device has to be considered. Uveal effusions are common in 2.9 to 9.3% of cases. A uveal effusion is seen. It can be drained by a subscleral sclerectomy. Scleral windows are made at the equator, 1 millimeter posterior to the recti muscles. A 4 to 5 mm scleral flap is made, which is around 70 to 80% in depth. Then in the residual bed, an incision is made and a window is created using a scleral punch. After that, you can either excise the scleral flap or suture it loosely, and this helps in draining the effusion. Residual refractive error is seen in around 40% of cases. It can be corrected by using a secondary piggyback IOL if not put in the primary surgery. Laser refractive surgery, contact lenses, spectacles, and IOL exchange are other options. Depending on the pathology of the eye, we can decide which option to go with. So, as discussed previously, if you place two IOLs, especially if the two IOLs are of the same material inside the bag, then interlenticular membranes will form. And YAG or an additional intraocular surgery would be required to clean up this opacification. And complications associated with piggyback IOLs are is that it scrapes the back of the iris, and it may result in pigment dispersion and iris transudation defects, or in severe cases, a UGH syndrome. So the take-home message is, firstly, cataract surgery on small eyes requires meticulous planning, and patient counseling is very important. These eyes have higher rate of complications and have delayed postoperative recovery. There is unpredictability in postoperative refractive errors. You need to familiarize yourself with sclerostomy techniques before going in for the surgery, and a VR surgeon support for vitrectomy, if needed, should be available when you go for the surgery. Thank you.
Well, that was a wonderful lecture. I think you covered almost all of the parts. And for postgraduate perspective, you may get a short note like nanophthalmos or this thing, or it may be a surgical viva where all these complications may be asked how to manage. No need to know the details of about each and everything from exam perspective. And this cutoffs like nanophthalmos, what is anterior microphthalmos, that is often asked by the examiners. So you should mark up these things. And add only one thing you people should remember, because most of the time you people would be doing the work. First, evaluate the visual potential, which she rightly pointed out. Most of these cases may have no visual potential at all, and you jump onto the surgery and you land up in trouble. And the patient's eye will become, which was earlier it was blind, it was now a painful blind eye. So case selection is very important. Rest of the steps, she rightly said what all precaution need to be done, and how the IOL power calculation to be done, and the piggyback, all sort of piggyback IOL, and all these things are there. But although I haven't operated on much such eyes, but normally the outcome in such cases is usually disappointing for the surgeon. And I think with this, I'll ask the Garbita to invite our chairperson, and then we can take on the questions from postgraduates.
Excellent
Arvind,
presentation, Dr. Komal.
Thank you.
So you covered almost every aspect. So the difference between this microphthalmos and nanophthalmos, that in microphthalmos, at least we have a very good ACD to work with. But in nanophthalmos, we have the short axial length as well as the very congested, crowded anterior chamber. So that makes phacoemulsification very difficult. And then pre-operative examination is a must. The horizontal wide to wide diameter, that is a must. The condition of the endothelia, that is again a very great prognostic factor, as rightly said by Professor Prafulla. Right, so we need to consider a lot of things. And then counseling is very important in such kind of patients. Then the formula, so it's the fourth generation and the fifth generation works very well in such kind of eyes, but still there is refractive surprise because SRK doesn't work well in such kind of eyes. So it's only the fourth and the fifth generation that works well. Now coming to the surgery, right? So by giving mannitol and Dimox is not sufficient because that will reduce that vitreous volume only by 7%. So I prefer this pinky ball for 15 to 20 minutes, and it reduces that vitreous volume up to 25%. That is a great help in such kind of cases. And then phacoparameters we need to keep at a very low parameters, so without harming the endothelia, because we have very lesser space to work with, and proper use of OVD. And in such cases, the iris prolapse is there. I had seen a lot of cases. So instead of limbal based, we can go for the clear corneal incision. In such cases, that will prevent the iris prolapse, right? So I'm happy to take any questions.
Sir, we have one question in the chat box. Please elaborate on causes of uveal effusion, how to diagnose and how to prevent it from developing in small eyes to be taken for cataract surgery.
Yeah, Dr. Komal?
I think I've discussed it. So, uveal effusions occur because there is choroidal and scleral thickening. So, it increases the vortex vein pressure, which leads to transluminal exudation of fluid. And because of this thickening, the outflow is limited. So, this fluid keeps on collecting inside the uveoscleral complex. That's how we see the those lacunae and cysts on the ultrasound B scan. And to prevent it from developing, if you are taking up the patient for a cataract surgery, if there is high risk, then we can go for the sclerectomy or sclerotomy procedures. So that decreases the risk of developing these uveal
So when we
effusions.
are operating such kind of cases, sclerostomy, we must know how to do it to manage such uveal effusion. And there are increased chances of this aqueous misdirection also, which can lead to malignant glaucomas also in such kind of eyes. So we need to be very careful at each and every step while operating such kind of patient. And most of the patient, as rightly said by Professor Prafulla, they have very poor visual prognosis. And also the amblyopia. The anisometropic amblyopia is seen in most of the patients. Dr. Prafulla, your comments? Any more question, Dr. Gavita?
Yes, sir, we have more questions, sir. The question is,
Garvita, my internet is not well, I guess. So you carry on with the question answer discussion.
yes, sir, I'm just reading the next question, sir. The question is, thank you, ma'am. Could you please elaborate why piggyback IOL?
As in these cases, the IOL power is very high, and the IOLs available to us do not match up to those power. So either we put a low power IOL in the bag and give the patient a +6 or maybe +8 diopters of spectacles, or we can put a piggyback IOL in the sulcus, make the patient comfortable, maybe emetropic, or have a less amount of hyperopia. So that's why.
So if we put two IOLs in the bag itself, so there is this problem of interlenticular membrane, there will be opacification very soon. So piggyback IOL in the ciliary sulcus, so there is a distance in between those two IOLs. So that is a great option.
Also, if the two IOLs have different materials, like an acrylic IOL in the bag and a silicone IOL in the sulcus, so there is less of biocompatibility between the two, and it also reduces the chance of these membrane formations and opacifications.
Also, few companies, they prepare this customized IOLs. The only loopholes of that is the lens becomes very thick.
Yeah, so it's always better to go for two IOLs instead of one with such thickness.
Thick IOLs, also there is difficulty in loading in the cartridge because they don't fold very well.
Yeah, you cannot inject them through the normal cartridge. There are special cartridges. Komal, any experience of use of contact lens in this patient?
No, sir.
Okay, normally that is a challenge in these cases. Normally you can compensate instead of, this piggyback IOL concept is still very new in India. A lot of surgeons are not comfortable with that idea. But unfortunately, in this group of patients, no, contact lens fitting is a big issue. We have tried in few per patient by adjusting the contact lens diameter. 50% of patients they do well, but
Okay.
the results are usually disappointing.
Yeah, Professor Prafulla, we even tried this ICL also, and they work very well with the remnant refraction. So they are also working well. We had operated 18 cases. So that is also I think, a futuristic option.
Yes.
But we
We
need
can
to
move
have
on to
good
next questions.
ACD,
Garvita.
good
Yeah, yeah.
ACD.
Garvita, any more questions?
Just one last question. Same material IOL can cause membrane formation. So, which material combination of IOL has minimum chances of membrane formation for best outcome?
Most commonly, it's acrylic and silicon, but the availabilities of PMMA IOLs is also there, so it can be, you know, sir would like to elaborate, sir.
Yeah, and along with superior PI, we can go without any hesitation. I always prefer to do superior PI in such kind of cases.
Those were all the
I
questions.
think the question was about combining the IOL, right? In piggyback, we don't have much choice at present,
Yeah.
right? So if you're planning, most likely you have to put a hydrophobic in the bag and hydrophilic in the sulcus. That is what I think currently most of the piggybacks are hydrophilic in nature. So that is what the combination wants to try. And that is in fact the best combination. We always prefer a hydrophobic lens in the bag because it's more bag friendly and it's good to put an hydrophilic in the sulcus. But the only thing is, the cost, everything that you have to discuss with the patient because if the patient after doing all these things, if he gains 1/60, then he'll be after your life.
Absolutely. So this counseling is very important in such kind of cases.
Garvita, any more questions?
No, sir. All questions are answered, sir.
Then you can conclude. Let's join the next webinar. But Komal, in nice talk, there is always a confusion while defining nanophthalmos. Only one point which it's for me, all these definitions are based on Caucasian eyes. Like if you label less than 21 as nanophthalmos, and you
Yes, sir.
won't believe 10 to 20% of our cases are in that range.
Yeah.
Indian patients, so this definition is a little bit confusing for me. At RP center, clinically anything less than 19, we consider that okay, this is a small eye.
So
20,
there,
21, we perform just like we take it just like a routine cataract only.
yes, sir. So we do the same, but all the literature, there is a discrepancy because I found literature saying defining nanophthalmos as axial length less than 19.5. But like most of the papers and most of the literature on nanophthalmos had less than 21 along with sclerochoroidal thickness. So that's
Yeah,
why I put it.
sclerochoroidal thickening is important, but if when you consider axial length in Indians, 21 is, I think, Arvind sir, what is your take?
No, that's
Yeah,
totally
21, I think is absolute go for a normal phaco, I think. In
Yes.
my experience of, I think, 20 years in pediatric eyes, but yeah, we need to go a little bit lesser values when we are finally saying that it is nanophthalmos eye.
yes.
So I think we need a chapter from RP Center on this.
No, sir, from you. With 20-year experience, you have experience
I
of
will,
both
I will.
adult
Definitely, I will.
pediatric
I
cataract.
will. Definitely, I will.
Yes, sir. So, Garvita, I think we can conclude now.
Yes, sir, definitely. Thank you, Komal ma'am, for that wonderful PPT which answered all our questions. Thank you, Dr. Arvind sir and Dr. Prafulla sir, for your kind inputs and extensive views on this very confusing topics. So thank you so much. I'm sure
it's a very complicating, intriguing, and very controversial topic. So hats off to Dr. Komal. You covered all the aspects in a very simplified form.
Thank you, sir.
Congratulations, Dr. Komal.
Thank you so much for your insights, sir. Thank you, Praful, sir. And thank you, Garvita, for moderating the session.
Thank you.
Thank you, everyone, and good night.
Good night.
Good night, everyone. Bye-bye.